It's Adam Farkas. Welcome to another ODwire webinar. Thanks so much for coming out again tonight. So dry eye disease and cataract refractive surgery, a case-based discussion. And tonight's a special one too, because we have my favorite kind of webinar. We have a tag team, an OD teaming up with an MD to talk all about how to sort of optimize the ocular surface before surgery, right? Because we all know that surgical outcomes are impacted greatly by the condition of the ocular surface. So I think it's incumbent on everyone to make sure that that surface is as good as it can possibly be before the patient hits the OR. And to talk about this with us tonight, we have a man who you've seen many times before on ODwire webinars, Dr. Mile Brujic, who's a partner of Premier Vision Group, and he practices full scope optometry with an emphasis on ocular disease management. He's on the editorial board of several optometric publications. He's published over 350 articles, given over 1,600 lectures, done more ODwire webinars than I can count, also participating at CE Wire coming up this weekend. And so I can't think of a better person to give you sort of a good broad perspective on getting the ocular surface ready from an OD's perspective. And we also have an MD with us tonight. So Dr. Ranjan Malhotra is a board certified fellowship trained ophthalmologist from the St. Louis area, and he specializes in corneal and external disease and refractive surgery. He's participated in many FDA trials and is the primary investigator in these trials for many of the medications that you all know and love. So again, I think we're going to have sort of a dynamic duo here with us tonight to really help us understand these issues and to try to get the patients well controlled before they ever get to the OR. So with that said, why don't I flip control on over to Mile and he can take it away.
Adam, thank you so much. Thank you for having us on. Ranjan, thanks for being here as well too. I think this is going to be an appropriate and a timely conversation as we talk about this, because we team with our ophthalmological counterparts on a daily basis with those patients who we are seeing that do have cataracts and do require surgical care. And I think it's important and timely because of the fact that the prevalence of dry eye is just one of these conditions that we're now seeing and is ubiquitous in many of our practices. It's prevalent. We know that the studies vary, and here's the challenge with dry eye disease. If we were to ask several colleagues, I think we would all identify it and define it a little bit differently. So even when you look at the studies, anywhere from 5 to 50% of the population, depending on how dry eye disease is defined, has dry eye disease in those respective studies. And when we do a deeper dive into this, we realize that almost half of Americans suffer from some type of symptomatic dry eye issues. 47% of Americans say they experience frequent or occasional dry eye disease. That's not a kind of the chronic patient. That's an individual who may have episodic dry eye conditions, but certainly something that we can manage. Younger individuals are oftentimes increasingly affected because of increasing screen time. And screen time for all of us has changed the environment. People always ask, well, why do I have dry eye? And I always say it's a combination of two things. The first is how your eyes are naturally producing their own tears and the balance of those tears. And the second is the environment that you find yourself in. And computers are just a stressor to that environment. And then among dry eye sufferers, 75% of them find their symptoms extremely or somewhat bothersome, and 67% or 2/3 of patients have had to cut back on daily activities due to the symptoms that they experience. So this is part of the reason why we're talking about it and where we're discussing it this evening, because it's so critically important, in particular when we're talking about the cataract patient. Now, Ranjan, when you think about, especially like, you're a surgeon that I would be working with in Northwest Ohio, and when I send these patients to you, it will affect one, not only pre-measurements, but also post-surgical outcomes. I'm assuming that you'd likely want this individual to at least be starting some type of regimen or be controlled in terms of their dry eye so that you'd be able to kind of jump into the measurements sooner. Is that a correct assumption?
No, absolutely, Millie. I think that a lot of these patients, and to your point, it's so prevalent, but it's also not recognized by the patient, and sometimes even by the physician, because the patients don't have typical symptoms of dry eye. And recognizing it and addressing it, and also maybe even communicating to the patient that it's actually affecting their eyesight. It's not just foreign body sensation, the typical dry eye symptoms. It's affecting their eyesight. So I think addressing that, educating the patient that, let's say you're referring the patient in for cataract surgery, explaining to the patient that part of the reason they can't see is their ocular surface, and then I'm going to send you to the surgeon to do the surgery. We got to fix both, and kind of almost like breaking it down and say, hey, 70% may be the cataract and 30% may be your ocular surface.
So you bring up such great points, Ranjan, and it's interesting you bring that up because it's part of the reason why I wanted to share this next part with me. So I've been passionate about dry eye disease since about 2005, and I graduated optometry school in 2002. And the reason why this happened was I had a patient shortly after I became a partner of the practice that I'm currently in right now, and I saw her for her initial visit. And she came in and she was getting her first pair of progressive edition lenses. She was a female that I used to refer to as an older 42-year-old female. I'm 49 years old now, so I refer to her as this young, hip 42-year-old female. But we prescribed her glasses. She came back a month later and she actually shared with me at that visit, she said, I can't see anything out of my new glasses. So as I was talking to her, I realized there were visual fluctuations as she was communicating about the eye chart and talking about how she was seeing things. And when she was reading the eye chart, she was blinking like crazy. And when I took her glasses off and I stained her, and again, in 2005, that's kind of all we really had diagnostically. I saw her tear film breakup time was almost immediately. I saw a band of corneal staining inferiorly, and I saw immediately why she wasn't seeing well. It was actually a dry eye issue. Now, she never complained about dry eyes the first visit, but as we kind of think about this patient, she came in particularly with visual symptoms. And what we ended up realizing was that those visual symptoms were secondary to an ocular surface issue. She didn't even think about bringing up her symptoms because she said she had been to so many doctors prior to that who just told her to use artificial tears that she didn't want to just bring it up because she thought, I already kind of had this managed. And in actuality, it was my first kind of real dose in clinical practice where this is not only I feel my eyes are dry, but I also can't see as well as I can. And that's where we started getting very aggressive at identifying these patients to help the optical portion of the practice to make sure that when patients are spending good money on glasses, they're getting the best refractive outcomes. But that extended very quickly to contact lens wearers. That also extended very quickly to our LASIK patients, and it also extended very, very quickly to our cataract surgery patients. This is the case in particular, Ranjan, where I gained a new appreciation for the surgical considerations that the surgeons have to go through when you're seeing these individuals. This was a 72-year-old male. He's in for his yearly exam, and he says he's noticed some visual changes. Last year, his best corrected visual acuity was 20/25 in each eye. This year, his best corrected visual acuity is 20/40 and 20/30. It's reduced secondary to cataracts in both eyes, and fortunately, we have a great network of surgeons in Northwest Ohio, great outcomes, 20/20 after the surgery. But after about 5 to 6 months, he came back into the office and he said, I'm not seeing quite as well as I used to. And he even told me, he said, I have some friends who went in after and had to get laser done to their eyes. And I'm wondering if that's something that I have to do. His lenses were still clear, capsule was still clear. But what I realized very, very quickly was he was looking through this what I would refer to as an unhealthy ocular surface with unstable tear film. And you can see it at 0, 2, and 8 seconds. And you can also see it in real time inferiorly at the bottom of the screen. The point here being, when they first come to present to us, they may not complain about vision issues, these cataract patients, because the 20/40 or the 20/30 cataract is blocking a lot of these visual issues. And now when we place those nice clear lenses inside of the eyes, they expose the perfection of the optical system that patient has, and they will notice a lot of these subtleties. Ranjan, what's been your experience with this, and in particular patients that we haven't treated on the front end and now have to work with afterwards?
Yeah, my analogy to patients, I tell them, it's like having mud on your windshield and you don't see the crack on your windshield until you clean the mud off. And so, for example, they don't notice their dry eye, to your point, because their cataract is kind of hiding their dry eye. Mm-hmm. And a lot of times these patients, their signs and symptoms don't correlate, so they don't feel as bad as they look. And And so that's why identifying it ahead of time, because we know they get worse after surgery, commonly after any kind of refractive cataract surgery or even refractive surgery in general, LASIK.
So Ranjan, here's where we kind of get into the fun part, is because now we both, I think, want to help each other as best as possible. We both want best outcomes for patients. So what I'm going to go through here in the next 10, 15 minutes is go through a little bit of the diagnostic algorithm that we look at. And the first thing that I wanted to point out is something that's just a different way to look at the eye. Jim Reinerson actually put this together relatively recently, and he's referring to it as the Reinerson red line grading scale. And what you can see is this hyperemia along the lid margin as you progress from the left side of the screen to the right side of the screen. And the way that you see this is you look at the patient with the naked eye and you just pull that lid up, and you can see the hyperemia around the lid margin that we're not supposed to see in these individuals. Again, normal on the left, highly abnormal on the right. And this is just a sign of inflammation. This is the first sign that something's happening at the ocular surface that we need to address. Now, whenever we talk about the ocular surface, we always think about the surface itself, but oftentimes it's the structures that support the surface that are most important. I want to give you a perfect example here. This is a patient who came to the office complaining about dry eye symptoms. Now, at a low magnification at the slit lamp, you may say that this individual has a collarette or a few collarettes. When you increase the magnification at the slit lamp, you get a greater appreciation for this patient's collarettes. Same patient, just an increased magnification. I'm going to show you one more mag up, and you can truly see what's now occurring. And I'm actually going to give you one more level of magnification. And you can now truly see what's happening at the lid margin that may be affecting the quality of the tear film. So it is important that we go through this systemic process from the front, to the back, to make sure that we're ruling out all of those things that can potentially cause dry eye symptoms, whether they be uncomfortable eyes or fluctuating vision. You know, here's the thing that gets the most attention in eye care is meibomian gland structure. Here's the thing that I want to share with you, where if you have advanced technology, it's fantastic, but if you don't, you can still examine the structure. This is simply me pulling a patient's lid down and looking at it with the naked eye, and you can see the meibomian gland structure that are present, and you can actually see where the meibomian glands are, and you can see where the meibomian glands are not in this individual or this patient. Again, very, very easily seen just by the naked eye. This is just an iPhone in free space, not at the slit lamp. When we get to the slit lamp, we can actually see it even a little bit better without any infrared imaging, and you can very clearly see where the meibomian glands are and where the meibomian glands are not, or where they're dropped out. Now, one of the tests that I love to use as a screening tool is the eyelid transilluminator test. You just take a standard transilluminator that we all have in our offices, and you leverage it underneath that lower lid. You shine it up through the lid, and you can very clearly see where the meibomian glands are represented by the dark regions where the light isn't shining through the lid, where the meibomian glands are not, which is that pink region superiorly in this image. So again, where they are is very clearly seen, and where they are not is very, very clearly seen. So we use all of these as screening tools to determine whether or not we want to take meibography on these individuals. And if there is dropout, we then resort to meibography, and you can see a typical lower and upper lid. And we're fortunate that there's a number of technologies that give us the ability to do this at this point. Infrared technology is based on a simple principle, and that is it detects metabolic activity. And because the meibomian glands have more metabolic activity than the surrounding tissues, they tend to look white on the meibography. Unless you have the lip of view, where it'll actually, the meibomian glands will look dark because it's actually shining light through the lid. Very similar principle to the eyelid transillumination that we saw in the previous slide. And this is really the scale that was put in place to share with us clinically what we're looking at structure-wise with the meibomian glands. When you look at the top of the scale, you see the meibomian glands that are full and 0 degree of loss. And when you go down the left-hand side, you can see where you have the most severe loss at what's referred to as a degree 4. This is commonly referred to as the Heiko-Pultz scale, the first individual to really kind of formalize it and put it together. I had the good fortune of meeting him at a conference in the Netherlands several years ago. Just an absolutely awesome guy, and contributed great to the profession as well too. And what you're looking at here is meibomian gland expression, and we're looking at functioning glands here. So how would a gland function in this instance? And what we're looking for is what happens when we attempt expression. And we can do that with a gentle finger press along the lid margin, or we can do that with something referred to as the meibomian gland evaluator, or the MGE. And that's what you're seeing here. And in this individual, what you're seeing is that there really isn't any type of meibum that's coming from this lid margin. And because of that, we have what's referred to as a non-obvious meibomian gland dysfunction. Now, all of these give us clues as to what may be causing the dry eye issues on the ocular surface. But there's other things that we have at our disposal, specifically our vital dyes, the fluorescein, and also the rat number 12 filter, that I think are probably the two most valuable diagnostic tools we have in our offices. And what you can see here is you can just see a lot from a standard fluorescein assessment. At 0 seconds, 2 seconds, and 8 seconds, what a tear film breakup time is not supposed to look like, because we know that a healthy tear film shouldn't show any dry spots for anywhere upwards to about 10 seconds or so. But it makes the invisible visible. That's what I love about the vital dyes. So when you look at the patient on the left, for example, this patient has what I would consider a mild inferior corneal staining. But without fluorescein and a rat number 12 filter and a cobalt blue light, that would be oftentimes missed on a standard slit lamp evaluation. When you look at the middle picture shows a little bit more staining. And when you look on the far right, you see that that staining pattern is much more coalesced. So again, in the more severe instances, you can see it at the slit lamp evaluation, but with the vital dyes, you can even detect the subtleties that start occurring. Inflammation is one of the other things that we can now measure, although there is a global shortage of this test. We use this relatively regularly when it is available. And essentially what you do is you take a small sample from the lower palpebral conjunctiva, snap it in the test cassette, dip it into the buffered saline bath, and then you wait about 10 minutes. And it tells you a few things. One, if you see a red line, you know that you have MMP9 present at a level greater than 40 nanograms per milliliter. If you have no red line, you know that the patient has low levels of MMP9. And if the patient, when you do the test, if they do have the red line, you also know that the patient's pregnant. No, you don't know that, guys. But this is a scale that Dr. Kading and I put together to give this test just a little bit more power. And what this scale was put together for is sometimes you'll run the test and get darker red lines, and sometimes you'll run the test and get lighter red lines. And the strength of that red signal is directly proportional to the concentration of MMP9 in the sample that you're actually collecting from the patient. There are other diagnostic tools that we have as well too. We have osmolarity readings, where we know that a higher osmolarity reading is abnormal and increases suspicion of dry eye disease. And in this instance, we're really taking a sample of the tears, collecting that sample of tears, and trying to understand what the concentration of solutes is in the tears. And then we also have a way to test corneal sensitivity, which is important as well too. Now there's more traditional technologies. What you're looking at here is the Cochet-Bonnet device, and you also see the cotton wisp tests, but there's more highly sensitive ways to measure corneal sensitivity now. About a year ago, we incorporated the corneal aesthesiometer in our practice. And you may be wondering, well, why would you want to know how sensitive somebody's cornea is? Well, the way that this test works is it blows a little puff of air on the patient's eye, and it puts that pressure of air on the eye at 5 different levels, with level 1 being the lowest level and level 5 being the highest level. And you shouldn't really be able to detect it at level 1, and most people can't even detect it at level 2. Level 3 is where most people can detect the puff of air. But if you can't detect it at level 4 or 5, that may be a hyposensitive cornea. And if you can detect it at those lower levels, you're dealing with a hypersensitive cornea. Why this is important is it starts to help explain why some of these patients early on in their disease have a higher level of symptoms than they do some of the signs that we see for them. And this is just a typical flow that we utilize in our practice that gives us guidance. And we didn't go over every single one of these tests for the purposes of time, but this is really a comprehensive perspective that gives you an idea of what happens in my office when we see patients. So they get a speed questionnaire if they're identified as dry eye patients. We do an inflammatory. I always assess lid seal. We apply fluorescein to the eye. We look for the Reinerson red line. We look at the lash margin. We look at the integrity of the meibum coming out of the meibomian glands. We also look at tear film breakup time and any staining that's physically present on the surface of the eye. And then we look at the lid wiper area as well too, which we know is an indicator of just comfort or poor comfort levels for patients. So, you know, when we kind of take all of this and take a step back from the diagnostic side of things, because Ranjan, you're going to give us perspective from the surgeon's perspective. I always think about optometry and ophthalmology as this kind of this pairing. Without either one of us, the patient doesn't get the best outcomes. So these patients oftentimes are living in our practices. So it's incumbent upon us to really identify these individuals and make sure they're receiving appropriate treatments. And when it's time for surgical intervention, we have ophthalmologists like Ranjan to refer to that we know we're hopefully going to set them up for the best clinical outcomes and the best measurements by providing them to Ranjan really pre-treated so that they're ready to go when they get to the surgeon's office. And then after the surgeon performs the procedures and is comfortable really co-managing with the colleague optometrist, then we really resume that care. And I think it's critically important for us as optometry to really kind of embrace this model, because if a patient has dry eye and we identify it before a procedure, it's a problem that the patient has that we're now helping them with. If the patient has dry eye but we don't identify it, and the patient has surgery, and then they start manifesting symptoms just because of the natural progression of the disease, it's now all of our problems, the healthcare provider's problems. So it's always best that the patient is as educated about their ocular health as possible. And again, I think the most important just takeaway from all of this is that it is critically important to provide the surgeons with the best ocular surface health we possibly can. And in doing so, we're ultimately going to provide the best outcomes for the patient. So Ranjan, before I hand it off to you here, I think it's important for us to take detailed histories beyond the standard complaints, assess things like tear film breakup patterns, and utilize the tools that we have in our office and set a kind of a diagnostic algorithm within your practices so that everybody can go through a standard series of whatever we're doing at the slit lamp in order to identify these individuals that may have dry eye. And we're fortunate now, we have a number of therapeutics, including over-the-counter, prescription, and also procedures that we can utilize on these patients. And certainly educating these individuals early is going to, in my mind, provide the best outcomes. I always feel like a more educated patient is always going to be a more successful patient. Ranjan, I don't know how you feel about this, but sometimes patients come in and they apologize to me. They said, well, I looked this up on Google, and they ask me questions, and I always tell them, I say, I'm thankful that you looked this up on Google, because now you have the starting point. It's now my job to put things into perspective for you, because I know that you're oftentimes reading this information in kind of this vast kind of space of emptiness. So I'm going to put all of this in context for you here today. So Ranjan, with that said, let's dive into more of the surgeon's perspective here. And now, as we get the patient to you, kind of what are you thinking with this patient?
Yeah, and dovetailing on what you said, I think educating the patient makes them more likely to be compliant too, because you're educating them as to why they need to be compliant for what you're diagnosing them with. So I think I agree 100%. Educating the patient is key to compliance. Okay, so some of my disclosures, as mentioned earlier, I do several FDA trials, and I'm on advisor or speaking for several of the different companies, but this is more of an educational talk, not a promotional talk. Okay, so Millie, you did an excellent job like kind of summarizing some of the demographics, but one thing, just to kind of bring up some of the demographics of dry eye and identifying these patients. So worldwide, there's 344 million patients that have dry eye disease, and close to 10% of those patients reside in the United States. but only about half of those patients are actually diagnosed with dry eye. So we're really underdiagnosing dry eye. And of those 16 million Americans that are diagnosed with dry eye, only about 10% of those, 1.5 million, get a prescription for dry eye. So so dry eye is not only underdiagnosed in the United States, it's really undertreated, especially when you look at prescription products. Millie, do you have any thoughts on why that's the case?
You know, part of the reason is I think dry eye is one of what I would refer to as the most gratifying conditions to treat, because when you get these patients happy, they absolutely, like, it's just a gratifying perspective from a clinician's mind, and they absolutely love you for it. But it takes a lot of patience. It's very rheumatological in terms of its management. And because of that, I think it takes a lot of patience. And because of that, I think a lot of eye care practitioners either just say, oh, just use whatever, artificial tears, or they kick them to other people who will take the time and the effort to manage these individuals.
No, absolutely. And I think a lot of these patients, unfortunately, they have a lot of signs of dry eye, but don't have typical symptoms of dry eye. So it's kind of easily overlooked. And a lot of times, even the treatments we had, especially I started doing this, you give me some of your history starting in the early 2000s. I finished I did residency in the late 1990s. And it wasn't when I first started my practice, the first prescription products out there were Restasis, the cyclosporin. We actually used topical cyclosporin compounded. And a lot of times the treatments for dry eye hurt more than the disease. Like patients would come in with dry eye, we'd put them on prescription products, and the treatments actually hurt more than the actual disease itself. And that's hard to convince a patient to take a medicine when it actually hurts more than actually their dry eye did. And so, and I'm sure we've all experienced that with a lot of the prescription products that we use. Let's go to this next slide. There's a delay here. Okay, there. So we know a lot of the patients that have dry eye don't necessarily have the traditional symptoms of dry eye. Sorry, it's kind of jumping around. And the typical symptoms being burning, itching, foreign body sensation. Sometimes they may just come in and see an eye doctor and just complain they can't wear their contacts as long as they want to, that they're having a difficult time reading as long as they want to, they can't work as long as they need to. They're having difficulty seeing at night. That's when I'm seeing them a lot. Patients are referred in for cataract surgery to see me for cataracts, and they have difficulty seeing at night, and they may have dry eye on top of their cataracts. They're complaining of blurred vision, but their blurred vision fluctuates. There may be times, they read for a while, then it gets blurry after reading. And so that fluctuating vision, we know is not a cataract, it's their ocular surface. They may have sensitivity to the light, and maybe even some reduction in quality of sleep. And as Millie kind of brought up, it could have an impact on several aspects of their life, including their vision quality, their success with contact lens wear, surgical outcomes, which we're talking about this evening, adherence to glaucoma therapy. And it's even a reason why patients jump from practice to practice, because they're not satisfied with maybe their vision quality or their tolerance of using their medication or even contact lens wear. And so they're going practice to practice when their problem's not necessarily addressed directly, meaning their ocular surface. So Millie brought up several different tests that are used for dry eye, one of them being the osmolarity test. The osmolarity test, as we know, is a test that's measuring how much salt and how many minerals are in the ocular surface in the tears. And we know a common result of any dry eye, whether it's aqueous dry eye or evaporative dry eye, is that the tear film gets hyperosmolar. And I try to relate this to a patient. And Millie, you said you live in Ohio, so I know you get snow and ice in the wintertime in Ohio, just like we do in St. Louis. And when you get salt on your windshield, it looks just like this, and you can't see. And if you turn on those windshield wipers over that salt, it smudges the salt. So I give patients this analogy: if we measure their tear osmolarity and their osmolarity is high, and they're even coming in to see me for a cataract, I'll tell them, gosh, you know what, we measured your tear quality, and your tear quality, the amount of salt in your tear should be around 250 to 300, and yours measured at 325. You have so much salt in your tears, it's almost like salt on your windshield. And so we need to give you something like windshield wiper cleaner to kind of clean off that windshield so you can see better, because that's partially affecting your nighttime vision and causing that halo and glare at night. And so patients kind of relate to that analogy, and we use different products. And sometimes if they do sting, if we put them on some of the cyclosporin or lifitegrast products that are prescription products, when they sting, I kind of tell them almost, it stings kind of like soap because we're kind of cleaning that salt off your tears. We know that that's not really what it's doing, but it's a way of a patient for accepting that burn to kind of get through that sting, to kind of get them to treat some of that inflammation on their surface. And we know that dry eye is a chronic disease. It's progressive. Many patients enter this this dry eye cascade through evaporation, sometimes through aqueous deficiency. The tears get hyperosmotic. They get inflammation, and that creates corneal surface damage, including not only SBK, but also nerve damage. And that's why Millie even brought up checking corneal sensation. I think that's where there's that disconnect between the way the patient's eyes look, their signs and their symptoms, is because they become neurotrophic, and that kind of further progresses their disease. They get this tear film instability, and they kind of spiral out of control. And that's the difference between a dry eye patient, because a dry eye patient enters this cascade and can't get out, where a normal patient could enter this cascade and then they get out of it. So that's the difference between a dry eye patient and a normal patient. And the common denominator of dry eye is, whether it's evaporative or aqueous deficiency, and sometimes it's a mixed bag, because by the time they present to us, it's usually both one affects the other. They get hyperosmolarity, and they also get inflammation. So ideally, we want to catch them kind of higher upstream, but once they get that inflammation, usually we have to use prescription products to treat that inflammation. And you mentioned several different treatment modalities. Artificial tears, and we have our favorites, and I'll talk about some of my favorites. Different devices. You talked about meibomian gland measurements, and then the devices we use to treat the clogged up meibomian glands. There are several devices out there, prescription medications and nutraceuticals, all that address different aspects of this inflammatory cascade. And some of the different treatment options are artificial tears. Some of my favorite artificial tears have sodium hyaluronate in it, or hyaluronic acid. One of my favorite ointments is Optase Hyalonite ointment, because it's a combination vitamin A lanolin ointment that kind of melts, has a low melting point, so patients could even tolerate it just even during the day, not just at night. We use different kinds of lid wipes too, because we know if the ocular surface is inflamed and not clear, that the eyelid, as you mentioned, collarettes, Millie, and blepharitis, and even Demodex could affect the ocular surface. So I explain to patients, we want to clean the river and the riverbank, because one has an effect on the other. Lid cleansers like hypochlorous acid, and then there's all the prescription therapies, including the different versions of cyclosporin, including Restasis, Cequa, and Vivi. Xiidra, lifitegrast, topical steroids now, some that are approved for dry eye. Some great new product called Mibo that stops evaporative dry eye. Xdemvy for collarettes and Demodex. Serum tears, and then even neurotrophic corneas using Oxervate for really severe dry eye. And mentioning some of the different procedures that are out there, LipiFlow, Ilux, tear care, microblepharo exfoliation, thermal pulsation therapy. There's a new treatment that we did studies on called Tixel, that's a high thermal response to help express those oil glands, and then even punctal occlusion as being a treatment therapy. And so the prescription products, going back to the initial slide of how we're really under-diagnosing and under-treating dry eye, one reason we may not be treating as much dry eye with prescriptions is that there's a really high discontinuation rate. So a lot of patients that start on prescription therapy, only about 30% of them actually stay on therapy, about 70% discontinue it. Millie, you have any thoughts on why people discontinue the drops, their prescription drops for dry eye?
Yeah, I think it goes back to the original kind of thing that we were talking about, and that is that dry eye disease is oftentimes very rheumatological in nature, meaning there's not something that's going to kind of fix it. Everybody wants the fix, and I think a lot of these patients need to be coached. And I'm concerned that when 70% of people discontinue, it's because they potentially weren't coached appropriately on the drops, and making sure they know that they have to stay on these drops in order to start seeing some of the efficacy over time.
No, I agree. And I think that goes back to, you said, when the patients Google, they have to be educated. but with a directed education by the eye doctor. So sometimes patients come in and see me and they've said, oh, I've tried Restasis, I've tried Xiidra, I've tried this prescription and it didn't really work, but they didn't define themselves, define like what's working. Sometimes if they didn't have any symptoms like foreign body, irritation, dry eye symptoms in their mind, if they start on the product and their symptoms, if they didn't have symptoms to begin with, it's hard to really improve their symptoms. But sometimes their symptoms are just visual improvement. So, and I'm sure you've seen this where you have a patient come in and as the case you showed where you have a patient that's 20/30, best corrected vision, you treat their dry eye and their vision improves, and they even come in on treatment saying, gosh, I'm not feeling any better, but you have to be a cheerleader and point out to them, hey, look, your vision improved by 3 lines or 2 lines. And they may not notice that improvement. So that's how you kind of have to define their success. I'm sure you've witnessed that before, right, Millie? Yeah, she nodded.
I would go one step further. I think it's incumbent upon us to actually help define those success markers for patients as well too. So I commend you on that because I think it's critical for us to remind patients that they are improving over time, if in fact they are, by the objective measures that we're taking.
No, I agree. So, I'm going to present a case, a cataract case that I had, this is a very common thing that we see in our practice. So this is a 74-year-old woman with blurred vision due to cataracts, wanting to see how she could see both distance and near without wearing glasses. She's asymptomatic except for having blurred vision that gets blurrier towards the end of the day. So there's a little like red flag there that it may not be fully the cataract because that kind of is worsening vision that fluctuates towards the end of the day. She's got a 3+ NSC. Some of the signs that she has on her exam is she has 2+ central corneal staining, SBK, a tear breakup time of less than 5 seconds. She has meibomian gland dysfunction and debris in her tear film and an elevated tear osmolarity test of 345 in the right eye and 320 in the left eye. She also does have symptoms on her OSDI. She's at 22. And again, she's complaining of blurred vision that worsens towards the end of the day. And this is a topography that was done just on her initial exam. And we do our assays, our IL Master 700 and the topography before even pressure is checked and before they're dilated on their exam, just so we get accurate measurements. You can see that's kind of an irregular amount of astigmatism. She was just treated with tears and came back the next day, and it actually looked like a little bit more irregular, almost like keratoconus. And so then we treated her for 2 weeks and had her come back 2 weeks later, and the astigmatism looked a little bit more regular. So you could just see just through the topography, and that's, even though we didn't mention that as a test for dry eye, sometimes that's a good way of me showing a patient, since I'm in Missouri and we're in the show me state, I kind of show the patient how dry their eyes are from sometimes on the topography, show them how irregular and how lopsided and irregular their cornea is to show them how the dryness is affecting their eyes. And this is a study that we were one of the sites for. It's called the FAAO study, and we looked at every patient that came in for a cataract evaluation, and 77% of those patients had corneal staining, but only about 22 of those patients had a pre-op diagnosis of dry eye. So they had corneal staining on cataract evaluation exam, so we know that's affecting their eyesight. There was another Duke study that looked at patients, and 64% of those patients had an abnormal OSDI score, where only 16% of those patients had a prior diagnosis of dry eye. And so this really exists in many dry eye patients. It's a comorbid condition. So as Millie kind of brought up, it's really helps a surgeon. It kind of like begs the question. Sometimes when I bring up dry eye to a patient, and if the referring doctor never mentioned it to them, they're asking me, how come I'm bringing up something that their referring doctor didn't? And I never throw them under the bus. I say, oh, we had all these tests. That's what kind of told us what it is. But it kind of puts us in an awkward position to kind of be the first one to bring it up when they've been seeing their referring optometrist for years. And so so it really helps us. I think to Millie's point, I wish you were in Missouri, because I think the more actively and proactively you treat this, it makes it much easier as a surgeon. I'm very happy when my co-managing doctors address and treat their dry eye preoperatively, because it really exists. So in that FAAO study, close to 80% of patients that presented for cataract surgery had visually significant dry eye, and a lot of them had signs of dry eye, but didn't have any traditional symptoms. Again, that fluctuating vision is a symptom of the ocular surface, not a cataract. And identifying these patients that have cataracts and dry is really important to kind of let the patient, they have two conditions, because only the surgery is going to only fix one of the conditions. And it's really important because we know that cataract surgery makes dry eye worse. And Millie, you kind of mentioned you mentioned this too, that like dry is a progressive condition. Do you think cataract surgery makes dry eye worse?
So I think surgeries get blamed for a lot of things because it's easy. And I don't think that that's truly the case. I think these patients, like even if you think of the LASIK patient wore contacts at some point, and then they started to have problems with their contacts. Well, what's the next step? The next step is let's pursue LASIK surgery. So there's probably some level of decline in the quality of the production of the tears that's already happening. And again, it's important for us to identify it, because then after LASIK surgery, well, they still have dry eye if we've identified it or if we haven't identified it.
Right.
So
no, Millie, I agree. I think it's even more simplistic than that. I think you mentioned the LASIK patient. In these cataract patients, if you take a LASIK patient that has a little bit of dry before surgery, you do LASIK, and of course after surgery they're not wearing their contacts anymore. And if they're not wearing their contacts, their evaporative dry eye gets worse because they just took the saran wrap off their eyes, right? There's nothing in front of their eyes. They're not wearing spectacles or contacts, and now their eyes are literally being exposed to the air more. And I think the same thing happens with our cataract patients, because many of our cataract patients, no matter what lens we put them in their eye, if they do, a multifocal, an LAL, a toric, even a standard lens with no LRI or anything, most of these patients, we're trying to make them they're prescription neutral. We lessen their myopia, or their hyperopia, and they usually see better without their glasses, better than they did before surgery, because most patients aren't plano to begin with. And because of that, they're actually getting some glasses independence, even if they're not paying for it. And when that happens, that simple exposure of not wearing glasses, because at least for the first week or two or a month, they're not wearing glasses anyway because their old glasses don't work. But then on top of that, they may be not wearing glasses as much or contacts because of what we did refractively with those IOLs. And I think just that simple exposure causes further dry eye. I think that I feel like it's an evaporative kind of dry eye they get from now their eyes are hitting the air more. And so common diagnostic tests, you don't have to invest in like expensive equipment for diagnostic tests or even have special tests. A tear breakup time is probably the most common test that I use to evaluate the dry eye, along with the vital tears, or along with vital dyes like fluorescein and lissamine green. Schirmer's test, which we rarely do now, unless we're doing studies. And then we do inflammatory, as Millie mentioned, and we do a lot of tear osmolarity testing and meibography. So I'd say at least many of our cataract patients get at least a tear osmolarity test and a tear breakup time, because that's our big screening test, and staining for our cataract patients, because it doesn't cost us anything extra, and it's something that's pretty quick to do in the office. And sometimes just looking at the patients, do they survive the cataract workup? Sometimes by the time they've had their biometry, their topography, we do an OCT, they've been dilated, got their pressure checked, their cornea looks like we beat up on it, and if they can't survive the cataract evaluation, sometimes that's enough stress to kind of break down their ocular surface. And as Millie had brought up, all the preoperative measurements, we're only as good as our measurements, so it has an effect on our IOL calculations if their keratometry readings and all of our measurements are not proper due to bad ocular surface. So we treat patients. We do use a lot of aura or intraoperative aberrometry. So we will repeat IOL calculations if they're really inconsistent when we measure them on their first cataract evaluation. But sometimes we could catch a lot of that when we do intraoperative aberrometry or when we do an aura to help hone in on our results. But it's super important for doctors that are doing light adjustable lens, because that makes those fine-tuning measurements even more accurate if the ocular surface is identified. So when I see a patient that has a cataract and I recognize even a small degree of ocular surface findings, I tell the patient, I go that, you're here for your cataract. I'm going to do your cataract surgery. This is the lens I'm going to recommend, but you also have really dry, chapped eyes, and 70% of the reason you can't see is your cataract, and 30% is your eyes being dry and chapped, and you have to use these drops because I don't want to get a C. I want to get an A, and if I want to get an A, you have to fix your dry eye, and I'll fix your cataract, and this way we could get you fixed 100%. And I feel like when I see patients as a second opinion as to even nothing's more frustrating. And Millie, I'm sure you've seen this too, where patients come in, had like a best corrected vision of 20/40 pre-op. They may have been a high myope. The surgeon did surgery. The patient's seeing 20/20 uncorrected, and they're complaining they can't see. And I would bet, a majority of the time that 20/20 unhappy patient is due to their ocular surface. And like you said, if you identify that patient's problem before they had surgery, it's the patient's problem. If you identify that problem after surgery, it's the doctor's problem and the patient's problem. But so it's really identifying that ahead of time is super, super important. So my preoperative regimen is, I'm skipping ahead here, is I like using a teardrop. So if I identify someone that has visually significant dry eye, I think I go to a prescription product, but I always use a teardrop, and I do like teardrops that have sodium hyaluronate or hyaluronic acid based tears. And one of my favorite tears that I use are the Optase line of tears, and there's several versions that are preservative free, either in vials or in a pump bottle, and they have a higher molecular weight sodium hyaluronate or hyaluronic acid that I use. So I'm using Optase either Hyalo Relieved or Optase Intense. And there's an Optase Forte that all have a high component of sodium hyaluronate in it. And I do feel like a lot of our patients have evaporative dry eye. So I feel like one of the gateway prescription drugs to dry eye is using Mibo. So I do use Optase Hyalo Relief, and then I chase it with the Mibo drop twice a day. I know that's off label because Mibo's QID. And I also like to use lid wipes because I feel like I want to clean the river and the riverbank. So I'm kind of using all three as kind of a step one. And I'd say a good 80% of my patients that have come in for cataract surgery that have dry eye, I'm putting them on this regimen. And I mentioned that's one, and I guess one reason that I do this, my in-house optometrists do this for me, which is great. And a lot of I work with 40 optometrists outside of my practice that I co-manage with. And I'd say at least half of them are doing a similar regimen, at least pre-treating the dry eye. I'm still working on the other 50% on getting them on board to treat their dry eye. But I think that this is something that I feel like really helps everyone, the co-managing optometrist, the surgeon, the patient, and it helps really with post-operative care. And if they need to go to step 2, this is something usually the co-managing optometrist adds. They'll add an ointment at night. They may add a prescription cyclosporin. I do like VVi because it has that same oil base as Mibo, or similar oil base as Mibo, or Cequa. And NXDembi is also a great treatment that helps with, there's some new studies that show it helps with MGD in addition to treating the Demodex. And then here's the different versions of Optase that have the HA. And there are other teardrops out there. I think Refresh and Systane in the past didn't have any HA, but they have newer versions. The Refresh Relieva has HA in it. And I think Systane has an hyaluronic acid based tear, and Ivisia has an HA in it also. And so does Blink Tears. And there's I do use for patients that maybe have nocturnal lagophthalmos or are on CPAP. This Optase hyaluronide is a vitamin A based. It also has lanolin ointment that doesn't blur as much, so it can be even used during the day if they have patients that have a little bit more of a severe dry eye. So some take-home points. We know that dry, about 77 or 80% of patients that come in for cataract surgery have concomitant ocular surface disease or staining of the ocular surface. Identifying and treating these patients with dry eye, even if they're asymptomatic, is important because we know that it could be affecting their eyesight. So it's going to just be a reason to help improve the patient 100% versus just 70%. And counseling these patients and letting them know that even though they may not feel their dry eye, that their dry eye is affecting their eyesight, I think that makes the patient more compliant, so that communicating and educating the patient that this is something that will help them see better, they're more likely to be compliant with this. And even if they fall off the wagon and they're not compliant, you can at least fall back and they'll remember you telling them this. And if the dry eye is severe, I'd consider repeating some biometry and tomography even after treating the dry eye, just because we want to get good measurements prior to surgery. So Millie and I would love to field any questions.
Excellent. All right. Well, thank you guys. So questions are rolling in, and I will see if I can get some interesting ones here. And by the way, everyone, you can use the question box on the right side of the screen, just where it says questions. Feel free to type in that question box, and we'll get your questions answered. So first question here, and this is actually an interesting one. I'll take it in reverse chronological order, I guess. Ranjan, you mentioned that only 50% of the optometrists that refer into you treat dry eye, before they send the patient over to you. Do you see that getting better or worse over the years?
Better. That has been better than it had been, because I feel like, but it's improved. I'd say about half. Like I'd say part of the referrals I get are referrals from Costco, Sam's, Walmart, and like America's Best, and they're not treating a lot of the medical diseases at those places. And then I would say most of the optometrists that come from private optometric practices that are treating a lot of medical diseases, they're addressing the dry eye. But we do have several optometrists that refer to us that are in some of those practices that are just purely vision, do vision.
Right. Question here, I guess this would be more directed towards Mille. Let's say you have a patient who you are referring out for surgery, and their ocular surface is a mess and it hasn't been adequately taken care of. What do you do knowing that you're going to be sending that patient out? How do you actually send them out the door, knowing that you may or may not see them again before they go to surgery?
So, Adam, that's a great question. I don't. I think you understand, Adam, that I'm of the philosophy that the more the patient knows, the more they're empowered. And I know that it's my job to clear up that corneal surface before it gets to Ranjan. I want Ranjan's job to be as streamlined as possible. And in order to do that, it's my task and my duty to clear up that cornea. So what we'll oftentimes do is we photo document everything. We have anterior segment cameras at every single slit, and we'll make sure we monitor that over time, and we'll start treating immediately. And we'll even give patients perceived expectations, usually with longer than expected guidelines, so that if we get them to a functional cornea sooner than that, they're happier, as opposed to giving them a short time frame and then not succeeding on those expectations. But we're trying to get those corneas as clear as possible before we get those patients to the cataract surgeon, because we know that they're going to still have to be treated when they get to the cataract physician.
Right.
And I think the patient will appreciate your thoroughness, as long as you explain why you're delaying their surgery or delaying sending the patient to the surgeon. You're saying, hey, look, we need to get your eyes optimized because this is affecting your eyesight before you even get the measurements for surgery. And I think most patients will appreciate that, not the rush.
Right. Interesting question here, and I guess it could be for either or both of you. How often do you use amniotic membranes for dry eye preoperatively?
Ranjan, do you want to go first? I'll take it.
Oh,
yeah,
I'll tell you my optometrist. So I could say I use amniotic membranes quite a bit for several different disease states, and I have used them for ocular surface disease. I have two optometrists in my practice, and they use them quite a bit to optimize the ocular surface prior to referring a patient to me for cataract surgery, but just in general for treating not just a mild dry eye, but more like moderate to severe dry eye, especially in patients that are neurotrophic, because I think it would help with the neurotrophic effects that dry eye causes it's where patients have significant signs like 4+ SPK and no symptoms, and they think they feel that the amniotic membrane helps it, like, even though it's maybe off label, but it helps regenerate some of that neurotrophic effect dry eye has, and helps
Agreed.
heal the ocular surface faster.
Ranjan,
they've had high success. Go ahead, Millie.
Yeah, I would say it's infrequent, Adam. We do use it. We have it in the back pocket, but we use it for other ocular surface diseases in more severe forms of dry eye. But it's infrequently utilized.
Right. Interesting question here. So you mentioned actually in a slide that the long-term compliance of medical therapy is rather poor. It's probably an understatement. What do you do in your practices to actually boost that? Are there any like concrete techniques that you have so that, it's I think you put up a number, 25% of patients are compliant in the long term. What can you do to try to make that better?
Yep. So Adam, I'll take that one first. Educate. Like one of the things that I already mentioned, Adam, is we have anterior segment imaging at each of our slit lamps. So patients know exactly what they're saying, and they know exactly why they're using the medication. I think that's one of the most important things, and I think that'll ultimately improve patient outcomes.
Esmeli, you must be from the show. Are you sure you don't have any Missouri ties from showing the patient so much? Because I think you show them the patient. Either show them, if you can have a picture of their SPK or their chapped areas in their eyes. Educate, like you said, educate the patient how it's affecting their eyesight. And that's why I like using the analogies of the salt on the windshield, cleaning the riverbank, and patients usually get it. And this way, I'm consistent, and I know I tell the patients the same thing. So if I see the patient 3 months later, I don't even have to open another chart. I know I told them, especially if I put them on that regimen, I know that's what I told them. And so just keeping things consistent. And I think having that consistency between the surgeon and the optometrist, I think that helps because they hear the message by all the doctors.
Right. Okay, great. And it actually looks like, amazingly, an hour has passed. So this definitely was an action-packed show. We have a bunch more questions here, but what I'd like to do is actually table them for now. And an archive of this webinar is going to be put up on ODwire as usual, and we'll place the questions over there as well. So people can come and watch the archive in the coming months, and maybe we can get the conversation going there as well. So Ranjan, Millie, thank you so much for doing this tonight. And again, the archive for the show will be up probably within the next couple of days, and I'd encourage everyone to come on over and take a look. So again, thank you both for being here tonight.
Thank you.
Thank you.
All right, and thank you everyone for coming, and I will see everyone online.